So thank you for having me here. It's very fun to have this discussion, and I'm very pleased to see that the field is moving the right direction for the patient, which is the thing that matters the most, and we're all in this for the same reason, so that's great, even if we might disagree at a certain point in history. So I just moved lately in New Jersey, where I'm the co-director of a big program, which actually opened my eyes on many things. These are my disclosure, and I have to say that I have a lot of them because I like to work with companies that bring the field forward and improve patient outcome. Even if I'm a United States based with Donald Trump as a president, I'm still very proud to be a Canadian, and that's me when I was actually in 1985. I was a skinny Canadian hockey player, and actually one of my idols was Wayne Gretzky, and this is him in '85. And one quote that I really love, what he said, is, I skate to where the puck is going to be, not where it has been. And actually, this is what the talk will be about. Where is TAVR going to be? No, not where he is right now, but where it's going to be. So that's the current guideline, actually, for TAVR. Just get updated lately in 2017. Unfortunately, just one day before the ACC presentation of core valve intermediate study trial. I'm going to talk about that, but TAVR right now is a class 1A for patients that are at probative or high risk for surgical AVR. They right now put a class 2A, which is reasonable, to be an alternative to surgical AVR in intermediate surgical risk. We discussed with Bob Bono, with Pat O'Gara. There's improvement ahead because right now we have two randomized trials that show at least equipoise non-inferiority with surgery. So it's going to be changed pretty soon to both class 1 for intermediate risk. If anatomically suitable, and I think we're going to talk about that later in the discussion. Maybe age is not the point. It's more about what is anatomically suitable for one or the other. So that's actually right now the algorithm. If you have severe AS and you're low risk, you go for surgery until partner or low risk trial will be published. It's class 1. Intermediate risk, class 1 for surgical AVR, class 2A for TAVR if there's compelling reason, and high risk and extreme risk is a place where TAVR might be considered as class 1 also. And this is, Jessica present these data. This is the important data you have to know for intermediate risk, well-designed, powered, randomized trial with patients that are comparable in both group. For the primary endpoint of mortality and stroke was non-inferior. TAVR was non-inferior for surgery. And when we look at the patient that were a good candidate for TF only, you have a trend to and a benefit for TAVR with 20% versus 16%. And when you look at the patient that only got SAPIEN 3, which is the new valve, not the historical valve used, and of course it's propensity match analysis. We can heavily critique these data, and I will do so also. But when you look at patient with a SAPIEN 3 valve appropriately matched, this is where you have a benefit of mortality, not composite endpoint, a benefit of mortality of almost half. With TAVR, 1% at 30 days, 7% actually at 1 year compared to surgery, 13%. So I think this is where at least we have compelling data to show that TAVR must be considered for intermediate risk. And again, this is propensity match analysis. We can debate all night on these. Also, core valve, the self-expandable valve was presented at ACC one day actually after the guideline was showed. And again, Jessica showed this slide. Non-inferior for the primary endpoint. For me, the most important finding is this decrease in stroke. TAVR got bad press, bad publicity at the beginning, more stroke. It's not the case anymore. At least you can say that the stroke is similar, if not lower, with TAVR in intermediate risk patient. So I think that's extremely important. We improve the profile, the design, the patient selection with these. For me, I mean, that's the most important slide for the next 10 years. One of the most important predictor of prosthesis failure in surgery is the EOA after the case in the mean gradient. Well, when you look at the core valve data, 2 years after, you have an EOA of 2.2 with TAVR compared to 1.7 with surgery. So you have to convince me to have very good argument to convince me that surgical AVR will have a longer durability than TAVR when you have such a bad start. So I can tell you that the main predictor of valve failure is the EOA after the case and after the mean gradient. So both advantages for TAVR, especially in small annulus. So just food for thought. This durability concept that TAVR will be less durable than SAVR is based on nothing. And I think here we have maybe a peek to what will be the future about the durability of TAVR, which I predict will be higher than surgery. So what is next for TAVR? So low-risk patient, we're doing a trial both for core valve and balloon expandable. It's going to be a non-inferiority trial at 1 year follow-up for both study with a 10 years actually follow-up. I think we're going to learn a lot with this. And again, it's good news for the patient as we are proposing more appropriate strategy for therapy. So what are the new indications for TAVR? And that's going to be what about my talk is about. So I can talk about TAVR will go where SAVR went and already succeeded. We're going to do TAVR for symptomatic severe AS at low risk. We're going to do TAVR for bicuspid. We're going to succeed. We're going to do TAVR for pure AR. We're going to prove that. Just be patient. We're going to do TAVR for concomitant AS with coronary artery disease, and we're probably going to do TAVR for patients with both mitral tricuspid valve. Just be patient. The field is moving, and it's good for patient. I think where TAVR will go and should go is where SAVR makes sense, but never succeed and is still struggling. Patient with severe AS with no symptom, when we want to intervene early, but the hit initially is too high with surgery. Patient with moderate AS, but very symptomatic patient with heart failure. So these are two categories where right now we're focusing our energy, and we're entering a very exciting era of strategy trial. So why TAVR will go where SAVR never been before? Actually, how TAVR is different, where it's less invasive, we all know that. There's less peri-procedural mortality and comorbidity. It's better tolerated by patient in case of a patient being unstable. You have immediate recovery. We have next day discharge, same day discharge in some cases, in crazy center, crazy operator, and actually largest orifice with the TAVR compared to SAVR. So that's the way I see the future, and that's the way I see AS in general. And sorry, I just got a 2-year-old baby, so I use primary color to describe life now, but this is where we are. Severe AS with symptom. Partner trial and core valve trial will show that this is green line for TAVR and high risk, intermediate and low risk. This is where we're in 2016. After that, there's this severe AS no symptom and moderate with symptom, where we're doing a watchful waiting strategy. Okay, and this is where we're going to investigate the field. Moderate AS with no symptom, we're going to discuss what we should do with that, and mild AS also. But right now, for the next 5 years, we're going to try to prove that by intervening early and in severe AS with no symptom, we may help patient, and also intervening early with patient with moderate AS with symptom, we may change, and these are already 2 trials ongoing, early TAVR and TAVR on load, that may help push the field and treat patient appropriately. I'm going to try to convince you of that. So 2 strategy trial, early TAVR for severe AS, no symptom, and TAVR on low for moderate AS with heart failure. So talk about a little bit about severe AS with no symptom. So these are the current indication for severe AS with no symptom. 3 class 1 indication. If you have a low EF less than 50, if you need a surgery, and if another cardiac surgery, and if you have clear symptom on the treadmill, meaning that you need to stress your patient. This is class 1 patient, class 1 indication for aortic valve replacement. There's class 2A also if you have a decreased tolerance on the stress test, your blood pressure drop on the stress test, meaning that you need to do a stress test in these patients, a screening model. And if you have very severe AS, peak velocity of 5 or 5.5, depending on the geography, class 2A. The problem with that is you have 3 class 1 indication, 3 class 2 indication. You have no randomized trials, all level B or C of evidence, and all retrospective data, which actually means that we need data to support these recommendations. So this is the current guideline. If you have severe AS with no symptom, the first thing to do is a stress test. It's in the middle. The problem is nobody's doing that. If you have a positive stress test, it's a class 1 to treat patient with AVR, whether it's surgery, TAVR appropriately. And then you have all the other class 2B. So if the stress test is negative, and if your stress echo is negative, this is where you do the watchful waiting strategy, where you follow the patient every 6 months to 12 months to reassess with an echo. So I think that's extremely crucial, because one of the problems is when it was highlighted in this publication in the European Heart Journal is only 6% of the cardiologists order a stress test, a treadmill, which takes 5 minutes for these patients, missing at least 50% of class 1 indication, patient with no symptom. which I think is really procrastination. It's not called clinical surveillance, it's called procrastination with this patient. And this underuse of the stress test is because of fear of the patient dying on the treadmill. They prefer to send the patient home dying at home, and actually their fear of having other type of complication on the treadmill, and they don't know how to interpret the test. So what is the practical issue with the watchful waiting strategy? First of all, as you see, the doctor don't do stress tests for these patients with a deadly valve disease such as AS. Second, the stress imaging or all that's needed special expertise in center. Not everybody is comfortable with that. That's another issue. When you follow these patients, the course of AS is so unpredictable that you may lose the window of symptom occurring, and then the next thing you know, the patient is dead. We have lots of follow-up patients, don't follow up and just go on vacation, came back 2 years later in the ER with EF of 40, 20, 30% in a heart failure, and you miss a window of opportunity. And there's at least between 1% and 3% of sudden death that occur during a year of this patient, which actually make me think that watchful waiting is more a wishful thinking strategy for the severe AS patient. So why early surgical AVR is not done more frequently in light of these data? First of all, the sudden death of severe AS, no symptoms, about 1% to 3%, and the perioperative mortality of surgery is about 1% to 5%. So it's not very compelling to say, well, to operate on a patient when you have such high morbidity mortality with treatment. Well, with TAVR now, it's maybe a better option for these patients, namely with the 30-day mortality of 1.1 that we saw in SAPIEN 3 data. It's become more compelling to believe and start to think that we may help these patients earlier with such a less invasive strategy. And this is the result of 30-day actually of TAVR versus surgery. That's the reason why surgery is less compelling in the concept with early intervention. When you see mortality, 1% versus 4% actually in partner, and also the stroke 1 to 4.4% with all cause of death and stroke 2 to 8%. But more importantly, when you talk to a patient actually, you have 6 more fold acute kidney injury with surgery, 10-fold time more bleeding, and 6-fold more time AFib, 5 versus 30%. It's hard to do a preventive therapy on someone and when you have 30% new onset of AFib. So that's a reason why TAVR might be more suitable for this, for these type of patients when you want to intervene earlier and prevent myocardial damage and death. So what is the prevalence of severe AS with no symptom? So are these patients frequent? When you look at all the data from the ECHO database, it's about 40 to 50% of all the patients coming with severe AS have no symptoms. It's half of them. So if you start to screen them, you may increase your volume by 2. If you remove all the concomitant valve and all the concomitant coronary disease that needs surgery, it's about 1/3 or 1/4 of your ECHO lab, meaning that right now there's about 500,000 patients in the US that are untreated with severe AS, no symptom, with only isolated AS, which is a lot of patients. So now, okay, what is the prognostic of these patients when you don't treat them? Well, we did a meta-analysis of all the literature lately, and actually we took only the 4 great retrospective series, for a total around of 2,500 patients, all severe. There's no contamination with moderate to severe because this is not the same population, only severe with strict criteria. And when you don't treat these patients with AVR, which was surgical in this case, you increase your mortality by 3.5-fold at 1 year. And actually, it was the same for cardiac death and rehospitalization. What about the stress test in severe AS? Well, we also pull all these data. We review the literature, and when you're severe on the right, severe AS, you put them on the treadmill, actually 50% are abnormal and 50% have a class 1 indication. Meaning that when you have a patient with severe AS, don't be afraid to put them on the treadmill. He's going to reach criteria half of the time. So you're missing the boat in half of them. And actually, if you put the moderate AS patient, 1/135 on the treadmill, 1/3 will be positive. So I think it's time to change our thinking about procrastination with these patients and to really do an active clinical surveillance which involves stress tests. If you don't intervene on a patient with a positive stress test, you increase your mortality by 6-fold of cardiac death. So not intervening on a patient with a positive stress test is deadly, and we don't stress these patients. So I think that's an issue. All right, what about the truly asymptomatic patient? You did your homework, you put the patient on a treadmill, is asymptomatic. Well, that's the Lancet paper, a beautiful paper, so I think should have more voice. They took 150 patients with a true severe AS. They removed the low EF. They removed moderate to severe other valve disease. They removed positive stress tests. They removed AFib. They remove the patient not able to do the treadmill. They have a pure population of severe AS with no symptom, and they follow them. Actually, at 2 years, half of them had a cardiovascular event. Not only AVR, 6% of them, 3% a year, has a cardiac death. So extremely high. 2% sudden death, and actually among the ones with an indication for AVR, 83% were for spontaneous symptoms. So you can say that within the next 2 years, you're going to have 50% chance to need a valve and 6% chance of dying. So the question is, why waiting? And there's another study that just came back a few months ago, was also beautiful, more than 500 patients. They exclude the same type of patient, and low-risk patient, 2.9% STS in average. They exclude all the patients with what we discussed, with low AF and other valve disease, and they look at all-cause mortality. This is what happened. Over the course of 12 years, if you don't have AVR, you die dramatically more. Of course, 12 years, you may switch category. You may become symptomatic after 1 year. But when you look at the curve at 2 and 3 years, this is where we power early TAVR, there's a 10-point difference in mortality, 1% versus 11%. So that's at 2 and 3 years. And actually, interestingly, what I like is if you do well on the treadmill, you do more than 85% of your predicted capacity met for age and sex, gender, and actually you have AVR, this is where you do the best. So you're capable to do a stress test, you're asymptomatic, you do great. On the other hand, if you don't reach 85% of your capacity and you don't have AVR, you're in trouble. And you have the spectrum, even if you do a good treadmill, you have no symptom of the treadmill, this is the yellow line, and you don't do AVR, you die more. So that's the rationale of intervening early, and it could be TAVR, but it could be SAVR. That's why we need to change our thinking about AS. So the question is, should and could we recommend early intervention strategy right now for truly asymptomatic severe AS patient? Actually, I'm not the first one to think about that. This is a paper, I'm very up to date with my literature, in 1965, Dwight Magoon, one of the most exceptional surgeons from the Mayo Clinic, who in 65 already advocate for early intervention to decrease the progression of this disease and decrease the depletion of the myocardial reserve. And actually, Magoon was an amazing man. He was a visioneer, he was a sailor, a pianist. He even wrote a book when he died from Parkinson. Actually, he did everything I never did. But he had a vision, and this is 1965 with surgery. So I think we're not the first one to have this idea, but I think it's time we change our mind about severe AS. All right. I see, when I talk to a patient, I said that severe AS is like the cancer of the aortic valve. And actually, when you look at the patient, from partner trial, every time I look at these data on table 1, okay, with baseline characteristics, it's ridiculous. We have patients, when you look LV dysfunction, 40% of them have LV dysfunction, 40% of them have prior AFib, 15% have pulmonary hypertension, and 5 to 10% have RV dysfunction. This is way higher for their age and sex. 15% of the patients above 75 should have AFib, not 40%. Actually, most of these patients already have a metastatic cancer of the valve. We wait too long. We wait for the EF to go down. We wait for the AFib to kick in. We procrastinated. Ideally, you want to operate on a patient who have no cardiac damage. You want to operate when it's still time to save muscle or life. And actually, when you look at the analogy of cancer, there's a grading of a tumor. You look at the tumor, if the cell divide fast or unfast, and you grade the tumor on G1, 2, 3, or 4 based on the differentiation of the tumor. But they also have a stage of extension. You have some nodes in the neck, in the armpit, in the brain, below the diaphragm. So whatever in AS, we are infatuated about the grading system, and we only look at the valve. How the valve look, how calcified it is, how open it is, what is the gradient, and if you're fancy, what is the flow? But we don't have staging, we don't have extension. What about a patient with severe AS, very thick ventricle, 3 times the normal for age and sex? It's okay, is it because of AS? Well, it's not okay, there's already fibrosis on the MRI. It's too late. And this is the natural evolution of a patient. You start, the patient has no damage, and if you wait, you have LV damage. If you wait, LA enlarged. This is the progression of left to right heart failure. If you wait longer, you have a PA pressure, and then you have pulmonary hypertension, tricuspid, and then if you wait, stage 4 cancer, RV damage. And you said, it is unpredictable and variable evolution. And you say to the patient, well, we're going to wait for symptom. I have no idea when the symptom will kick in. It could be tomorrow, it can be in 1 year, if you're lucky, 2 years. So I think it's time to change our thinking. And one of the things I just get under revision, going to be accepted soon in a journal, is does the extent of cardiac damage matter with severe AS? So we divide all the patient in partner in 4 stages of AS. The first one with no damage, the first one with LV damage, the second one with LA damage, third one pulmonary damage, and fourth one RV damage. All these patients are after successful AVR, TAVR or SAVR. This is the curve. At 1 year, you have 25% mortality despite a successful AVR. I don't know where you want to be operated if you have AS, but I want to be in the blue one. And this is the common dialogue we have with the patient. The doctor says, you have severe AS. The patient, okay, what should we do? And then you say, well, you tell me when you don't feel well. It's just unacceptable. I just think it's ridiculous. It's like to say to a patient with a lung cancer with no symptom, come back when you spit blood or you're short of breath. That makes no sense. And actually, this is the second quote of Wayne Gretzky that I really love. Procrastination is one of the most common and deadliest of disease, and its toll on success and happiness is heavy. So I think it's time to see AS in a different way, as a deadly disease, and not to think it's benign. And that's the reason why we designed the early TAVR trial that's going to already start, and I'm very lucky to work with a great group of people, and I'm going to be the lead PI on this. We're going to take more than 2,000 patients that's going to all with severe AS, no symptom. And we're going to do a treadmill, and we're going to randomize. If the treadmill is positive, with rigorous criteria that we already defined, we're going to treat them because we need to treat them. And if it's low risk, we're going to randomize in P3. If it's moderate or high risk, we're going to give them TAVR or SAVR based on the heart team discussion. If it's a true asymptomatic patient, we're powered to have 1,100 patients. We're going to randomize them 1-for-1, TF TAVR versus clinical surveillance with echo 6 to 12 months in clinical surveillance. Primary endpoint will be at 2 years. If we have enough event, 3 years if we don't. And we're going to follow these patients up to 5 years. And there's going to be a primary endpoint for superiority at 2 years with a primary endpoint of death, stroke, and unplanned urgent hospitalization. So I think this is where we are in this field. TAVR allowed us to dream about treating patients in a better way, earlier, not only in prevention, but in preemption of the disease. And I think if this applied to TAVR, could it also be translated to SAVR eventually. And we already consented the first patient March 16 in our center, and we're very thrilled about this trial. All right, a brief note on moderate AS with heart failure. So this is the bucket. You go on the left, you have patients that don't meet criteria, and you have this basket of complicated category of low flow, low gradient with contractile reserve, paradoxical low flow, low gradient, which is extremely confusing. And this is what the guideline is. If you have this entity, what you need to do if you have moderate AS, okay, to treat a low flow patient with AS, you need to prove with dobutamine echo that it's severe, okay? And same thing for ACC and ACC. But what happens if you have a patient with moderate AS, 1-3, 35, but still in heart failure? And he's coming, you say to the guy, you only have moderate AS, come back in the ER in 2 weeks, I'm going to see you with Lasix increase. What do you say to the patient? And these populations are frequent with moderate AS, and actually they just keep coming. And that's actually the TAVR on load trial that actually Nicolas Van Mingen and Marty Leon have designed. Jean-Michel Paradis is there, and is also part of the steering committee in Quebec, and really will explore a patient with heart failure, 50% to 20% EF, with moderate AS, with negative dobutamine, will be randomized to TAVR and optimal medical therapy versus optimal therapy alone. So again, the less invasive therapy of TAVR may offer an opportunity for these patients that are believed to be non-sick, but actually are the sickest of the sickest because it's probably too late. So just to come back actually to this colorful diagram of Sesame Street. So you have the patient on the right with severe AS with symptom. I think in the next 4 years, we're going to try to prove that we have to intervene earlier in the process. And I think that the active surveillance, where we need to start to be real doctors, is to screen patients with moderate AS with no symptom, to put them on the treadmill, to really inquire and follow them every 6 to 12 months, not 3 years, not 2 years. And actually, I think in 2020, we're going to start to treat patients more in prevention, preemptively, and that's what's going to look. So, and I think we should start to do population screening for this patient and really follow these patients appropriately, because AS is a deadly disease. It's not like coronary disease. It kills for sure. So in conclusion, I think TAVI tomorrow, for me, TAVR will go where SAVR went, if suitable anatomically, and I think it's important. Stratification by age, I think it's making nonsense. You need to look at the scan with the Aortic team. Is TAVR suitable, anatomically speaking? What is better for a patient at an anatomical point of view? TAVR may go where SAVR struggle, fail, or never been before, and I think these two buckets of severe AS with no symptom and moderate AS, it's a good example. I think for the first time, TAVR technology offers us a chance to treat patients appropriately before irreversible damage occurs, and I think that's a very exciting time. And it's going to help us to treat patients in prevention, preemptively, like a real doctor. So thank you for your attention.